All right, everybody. Since we're a couple minutes after the fact, we'll go ahead and plan on getting started. So Dr. Getz is here today to kick off our week to talk about kids with altered mental status, and he's going to do a little talk for us. There might be some overlap as we go from topic to topic this week, but that's all right. So we will let Dr. Getz get started with this week's topic. Go ahead and take it away, Dr. Getz. Thank you again.
Okay, and you can see everything okay? You can see the PowerPoint's okay?
Yep.
Okay, all right. Well, y'all just holler if there are any problems with it. And since it's the first time I've done this one, let me know if it's not what you want and if you want something different. Or any feedback, because appreciated. Okay, good, it's working. All right, so I kind of didn't know where to start, so I just said I would start from the biopsychosocial model perspective. The things that we would see biologically is kind of how I started, and I think that's kind of where a lot of altered mental status may come to be hospitalized, at least. So biological components are things like genetics that we would get in the psych history, like family and things like that. Family history, sometimes things like social referencing comes up, and that's where family styles of behavior, and kids will look at their parents and the family history. An example of that would be like, a kid that presents with altered mental status with anxiety because the parent is extremely anxious, which happens. Physical development, comorbidities, medical problems. This is a big overlap, or we might see some altered mental status with psychiatry and pediatrics, constitution type things. So vulnerable versus resilient. We get some kids in there who stub their toe and they'll have 11 out of 11 pain or 11 out of 10 pain. We might have some kids that stub their toe and have like a 1 out of 10 on a scale of 1 to 10 pain. Intelligence plays a role in our ability to have our coping skills and our ability to process stress. Inborn temperament, again, are we vulnerable or are we kind of resilient? Kind of glass empty, glass half full type thing. Medications obviously play a role in the biological components, and so do drugs of abuse. Some other things that you may see, things like, again, biological causes. There's a good many biological causes that might come up. Neuroplasticity versus neuroresilience, and we'll kind of talk about that. Basically, I kind of like to think of things in like terms of how many hits can we take? Everybody I'm talking to with y'all are very, have a lot of neuroplasticity and a lot of neuroresilience. Y'all could take a lot of hits cognitively and still keep on going, or some patients are born with less neuroresilience and less plasticity than others. So just kind of jump in there, when you think of altered mental status, some of the things you think might be medications. And again, I didn't know where to draw the line in terms of like psych versus medicine. So I just kind of, there's some overlap. But non-prescriptive medications, things where you might see altered mental status would be like antihistamines, dextromethorphan, like kids robotripping. Drugs of abuse, obviously that would be something like ethanol. We had a kid, the blood alcohol level of 1.9 in the ER. 13-year-old the other day got in a parent's liquor cabinet, drank about 10 shots of vodka. So he had some altered mental status, heroin, hallucinogens, like LSD, things like that. Cannabis comes up a good bit. And we'll have the non-medicinal use of prescription medications. I feel like we see a lot of that more often with overdoses. A lot of those folks will present with altered mental status. Withdrawal states, again, things like ethanol and benzodiazepines, they can have altered mental status. Medication side effects can play a role. So you might get the hyperammonemia from valproic acid, which is the medicine used for behavior, but also anti-seizure medication. You can get confusion from quinolones, serotonin syndrome. I feel like we've seen a couple of cases in the PICU of serotonin syndrome. How that presented with confusion and altered mental status and some overdoses lately, maybe like a month or two ago. Or even more severe things like neuroleptic malignant syndrome that you can get from like antipsychotics and anticholinergics. Poisons, had some cases of that over the years. Atypical alcohol, some kid will get a hold of some methanol or something like that, or antifreeze. Inhaled toxins like carbon monoxide, cyanide, hydrogen sulfide, those aren't quite as common, but those are also on the list. And plant-derived things like Jimson weed and salvia. I think, who was it? Miley Cyrus, a good influence to all teens, was using salvia on her birthday, as I recall, when she turned 16 or something like that. Don't do what Miley Cyrus does. Meds. Okay, so serotonin syndrome can be caused, usually we assume it's serotonin syndrome from serotonergic medications like SSRIs and SNRIs, but also you have to keep in mind things like the MAO-I inhibitors, stimulants, interesting enough, stimulants like Adderall and methylphenidate are actually act on the MAO-I pathway as well. Meperidine, sometimes we don't think about meperidine, but meperidine is one, and that is one of the main causes of why we have resident work hours. Meperidine was given in the ER in New York some time ago, had a bad reaction. They at the time assumed it was because the resident had not gotten enough sleep and had not been off long enough. Again, that was the assumption at the time, but we still have resident work hours. TCAs, tricyclic antidepressants, which were the precursors to the SSRIs and SNRIs, also act on the serotonergic system, and then trazodone is also one. Neuroleptic malignant syndrome. This is via dopamine blockade, which we often think of antipsychotics typically first. We think of things like Haldol, chlorpromazine, but also metoclopramide. Don't forget that metoclopramide can block dopamine as well. And significant shifts in dopamine in the brain can cause some altered mental status and movement disorders too. We had a poor girl with autism that did not have very much neuroplasticity and neuroresilience a couple years ago, developed altered mental status and movement disorders. And she had been on Concerta 72, got a, so her dopamine was elevated from her baseline. And she got a stomach bug. She started, I think it was metoclopramide for her nausea. But she stopped the Concerta, went to her baseline, then dropped even lower with the dopamine blockade of the metoclopramide, and developed movement disorders and altered mental status. And that was a really interesting case. Sedation. Well, sedation makes sense. That causes some altered mental status. So these work on some GABA pathways, anti-seizure medications, anticholinergic medications, sleep meds, blood pressure medications like clonidine, alpha-2 blockers, beta blockers, things like that. And sometimes we don't think about the steroids, but steroids can cause manic or psychotic symptoms. I think that's something that pops up in our boards books every so often. But we've seen some cases of that too. Usually it's higher doses of the steroids. So what is serotonin syndrome? Again, it can come from these serotonergic medications, but symptoms are things like agitation, restlessness, confusion, which is something that we often think of when we think of altered mental status. You can get a rapid heart rate, high blood pressure, dilated pupils, and this is something that we checked for last time we had one of these cases, and that was evident. Muscle rigidity, heavy sweating, diarrhea, headache, shivering, goosebumps, and severe serotonin syndrome can be life-threatening. That's why it's a lot of times we will see them in the PICU, but they can have high fever, seizures, irregular heartbeat, and unconsciousness. Typically, I see these in overdoses as opposed to normal doses of medications. I haven't really seen serotonin syndrome in anybody that was on a normal dose of medication. Usually I see these in overdoses. Once I saw an adult that was on the maximum dose of Zoloft, the maximum dose of Effexor, and a high dose of trazodone, and they got the flu. Treatment, so things like benzodiazepine medications help calm them down, Ativan to kind of decrease agitation, seizure-like movements and muscle stiffness. Typically, it's actually just supportive with IV fluids and withdrawal of the medications that cause the syndrome. But on the boards, often you'll see the cyproheptadine or periactin. Periactin can be the drug that blocks the serotonin production. maybe an antidote. I've seen this on the boards before. But typically what we do is just supportive. Neuroleptic malignant syndrome. Again, this is by dopamine blockade. It's less common, but can also be seen at higher doses of atypicals like risperidone, ziprasidone, olanzapine, quetiapine, aripiprazole, paliperidone. Those are all the new generation of atypicals. And you can see it when those doses are elevated because of the increased dopamine blockade. Again, medications that treat nausea like metoclopramide, droperidol, droperidone, prochlorperazine, and promethazine that block dopamine. It can be seen as well. And also abrupt withdrawal from dopaminergic medications can cause this as well. Similar to the poor girl we talked about earlier, significant shifts. NMS is more common in women than men. You're more likely to get it if you have a high dose of the medication, again, increasing the dopamine blockade. Quickly increasing the dose, so going up really quickly, getting the medication as a shot, say like Haldol IM preparation or something like that, and switching from one antipsychotic drug to another. A lot of these are less likely unless there's been some kind of change, unless it's something like, they do have a problem with like the flu or a stomach bug where they've had some change in their PO intake. NMS usually lasts for 7 to 10 days. I've seen this twice. Last time I saw it, it was a 9-year-old in the ER, and it came from an outside ER where a family practitioner gave the kid 50 times the dose of Haldol as recommended because the kid threw a chart at the doctor. And in that case, the kid did fine. He did have all the symptoms, but he just needed supportive care in the ER, and he was actually doing pretty good afterwards. But the symptoms are high fever, muscle stiffness, and this is why we sometimes will check labs to see what their CPK is, sweating a lot, anxiety or other changes in the mental state, fast or abnormal heartbeat, quick breathing, and hypersaluria or more saliva than usual. NMS can damage the muscles, cause very high or low blood pressure. If not treated, they can get other problems like kidney failure. I believe this comes from the protein blockade in the kidney from muscle breakdown. You get heart and lung failure, lack of oxygen in the body, infection in the lungs caused by breathing in fluid or aspiration pneumonia, and more acidity in the body. So as such, I should have done 2 slides on this, I'm sorry. Labs that you can check or you might see are increased LDH, increased CK, increased AST and ALT, increased alpha phosphatase, hyperuricemia, hyperphosphatemia, hyperkalemia, myoglobinemia, leukocytosis, thrombocytosis, proteinuria, decreased serum iron, increased CSF protein, hypocalcemia, myoglobinuria, and metabolic acidosis are all things that you can see in NMS. And what do we do about NMS? Interestingly, a lot of times we'll have folks that may be psychotic and have NMS, and that's where the problem is, because NMS can come from the blockade of dopamine, so adding an antipsychotic actually is not contraindicated because that can make it worse. So a lot of times with these folks, again, we'll do supportive care, stop the offending agent. Sometimes we'll use dopaminergic medications like dantrolene or bromocriptine or amantadine, and ECT is something that can be helpful in these cases as well. And we've done all these things before, actually. Catatonia. Catatonia is it's a very complex psychiatric and medical syndrome. The reason I put it here as opposed to in the psychiatric section is because catatonia, serotonin syndrome and NMS are actually both substance-induced catatonias. They technically fall under that category. Again, the serotonin syndrome is from too much serotonin, and the NMS is from dopamine blockade. But basically, catatonia is abnormality of movement behavior arising from disturbed mental state. It may involve repetitive or purposeless activity, catalepsy, resistance to passive movement, and negativism. Happens most often with people who have mood disorders or psychotic disorders, so things like severe depression, bipolar disorder, schizophrenia. And a third of people who have catatonia do have bipolar disorder. I think that's probably we've seen it the most, to be honest, other than medical causes like encephalitis. You can see it in those with limited neuroplasticity and resilience. Again, a vulnerable brain may be more likely to have it. We have several kids in our clinic that are on the spectrum that develop catatonic symptoms and one up in the Children's Hospital. Other conditions that affect your body chemistry, kidney problems, diabetes, thyroid conditions, Parkinson's, things that attack your body's nervous system. Again, Parkinson's is related to dopamine as well. Encephalitis. Encephalitis, we've had a couple of NMDAs over the years. We had a really interesting CMV. We've had some Epstein-Barr. We've had, I believe it was like a West Nile a couple years ago. James and I were talking about that. It may have been a West Nile virus encephalitis that led to some catatonic symptoms. But in catatonia, you may have any of these three symptoms for the diagnosis. Not responding to other people or their environment, not speaking, holding the body in an unusual position, mimicking someone else's movements or speech, so like echolalia, which is voice, or echopraxia, which is movements. Resisting people who try to adjust their body, agitation, and repetitive meaningless movements. And there's different categories. Akinetic catatonia is the most common. So this is where you see someone staring blankly. They can go from poor eye contact, fixed gaze, to no visual scanning and not reactive at all. Akinetic, you can have, will not respond to you when you speak to them, so they may be mute, will not move. Impotency or motorically stuck, immobility. Again, they won't move unless you move them, or they get stuck, like literally you just cannot move them at all. Again, they may mimic echolalia sounds, echopraxia is the fancy way of saying movements. They may sit or lie in unusual posture, posturing, catalepsy, maintaining a posture without reacting for less than a minute or over 15 minutes. So interestingly, just completely tangentially, I was supposed to do my grand rounds on spooky stuff in psychiatry Friday, but it got canceled. Catatonia played a big role in that because catatonia and rabies are the medical bases for zombies. If you think about it, catatonia, a lot of times in the past, we weren't very good at diagnosing someone as being dead. So if someone was staring blankly, not responding, wouldn't move, there was several interesting cases of this actually in Haiti, where the family presumed they were dead, and the patient woke up, started wandering around the island, and they thought they were a zombie. Excited catatonia. Excited, this is a type where the person may move around, but their movement seems pointless and impulsive. They may be agitated, combative, delirious, and they may mimic the movements of someone who's trying to help them. And we've had a couple of cases of these over the years, and they usually stir things up a little bit. Malignant catatonia. This one's dangerous, and we had, I don't know if you remember Shemaya from, I guess it was last year, Shemaya, where she had malignant catatonia. If she didn't get ECT every 2 weeks, she would have autonomic instability such that she could have died. She had really, really high blood pressures. She was getting ECT every 2 weeks. This happens when you have the catatonia leads to other health problems. So dangerous changes in blood pressure, body temperature, breathing, heart rate. Someone who's catatonic for a long time may be more likely to have problems like dehydration, blood clots, kidney failure as a result. And why is this important? Because there used to be a 90% fatality rate with malignant catatonia. some time ago. So this is why this is important. And again, it's the autonomic instability that is significant. And a lot of times these folks may not respond appropriately to the benzodiazepine. And that's why that can be really important. That's why these folks sometimes get ECT. Again, what's important. So the diagnosis is via the Bush-Francis scale. I usually try to show y'all that when I go over there to the Children's Hospital. I've got one of those over there, and it's in my drawer. So treatment, usually that it's recommended that they have a GABA challenge via Ativan, up to date, put in their catatonia recommendations. That you could try something like something else GABAergic, like a Neurontin, but typically it's a benzodiazepine challenge with Ativan. You can come if you want to. I'm just gonna let's see. If no improvement after titrating the GABAergic medication, then ECT is indicated. So you do the ECT if the sedatives don't work, if the catatonia is severe, the person has had catatonia before, and if quick action is needed to save someone's life, again, due to autonomic instability. I kind of threw this in there just because it's very important, and it's just one word because it is that important, but I have seen altered mental status due to lack of sleep. Yeah, and it's been several different things. We've had kids watch it, Drag Me to Hell, things like that, and then they won't go to sleep, and then they start acting after they don't have enough sleep for a while. They have had some altered mental status as well. Yeah, eight consults for It, the movie It, when it came out, because there were little kids watching it and they're all sleep related or seeing clowns in the walls. Delirium. I didn't know if I should go there or not. I decided to go there after texting Scott. But delirium lists 5 key features to characterize delirium: a disturbance in attention, reduced ability to direct, focus, sustain, and shift attention and awareness. The disturbance develops over a short period of time, usually hours or days, represents a change from baseline, and tends to fluctuate during the course of the day. This is where we get the waxing and waning. That's pretty typical that you might see with delirium. It's something to watch for. There can be an additional disturbance in cognition, again, a memory deficit, disorientation, language, visuospatial ability or perception. The disturbances are not better explained by another pre-existing evolvent or established neurocognitive disorder and do not in the context of severely reduced level of arousal, such as coma. There's evidence from the history, physical exam, or laboratory findings that disturbance is caused by a medical condition, substance intoxication, or withdrawal, or medication side effect. Additional features may accompany delirium, and again, confusion. So you might have psychomotor behavioral disturbances, hypoactivity, hyperactivity, with increased sympathetic activity and impairment in sleep duration and architecture. Variable emotional disturbances, fear, depression, euphoria, perplexity. So 20 to 30% of critically ill children may develop delirium. It's usually something that's seen in the PICUs. It can be a challenge. Risk factors are things like younger age, severity of their underlying illness, number of medications that they are on, diagnostic tools used, general ward versus intensive care unit, developmental delay, again, which is related to neuroresilience and neuroplasticity, and then having previous episodes of delirium. Common symptoms in children include a waxing and waning presentation, like we said, confusion. They may not know where they are, what day it is, who they're with, who they are. They can become agitated and restless. Is typically when we have some trouble with that. Picking at things that aren't there, being upset and not responding to usual soothing, trouble with attention memory, difficulty staying alert. Typically, attention is the first lost and the last thing that they get back from delirium. You can have sleep disturbances, new or different behaviors like aggression, suspiciousness, being withdrawn, talking in a way that doesn't make sense, seeing or hearing things that aren't real, and they can be hyperactive or hypoactive. Common causes, again, are things like underlying illness, medications, high fever, anesthesia, head injury, disruption of the sleep-wake cycle, not enough oxygen to the brain, drugs or alcohol, poisoning, electrolyte imbalances. Where does it come from? It comes from Latin delira, which means they are out of the track. And it is a neurocognitive disorder due to somatic illness and treatment, and its treatment. Again, these are several different causes. Here's a slide that shows the different scores that we can use. Interestingly, I am doing my maintenance of certification, and one of the articles I had to read talked about the PCAM in the ICU and the CAPD, and I thought was pretty interesting. These are the ones that they recommend the most. So those are one, and I don't know if we really use those in particular, but those are ones that we have available if we should choose to use them. So non-pharmacological interventions for delirium in children. I think this one's probably pretty important. So again, having the presence of a parent and soothing stimulation around a dim night light, day-night light schedule, so we can avoid sundowning. Familiar music, sounds, voices, smells, things like that. Favorite toys, pets, blankets, familiar photographs at the bedside. Staff psychoeducation to give reassurance and improve orientation. Again, kind of reviewing what day it is and things like that. And usually we can print up like a leaflet for parents on pediatric delirium. Optimization of the level of sensory stimulation. Again, in the case of hyperactive delirium, you can move to a single quiet room. If hypoactive delirium, you may want to increase social interaction. Again, you want to discontinue any medications that may reinforce the delirium, and we want them up and around as much as possible. So some parent recommendations. So be calm, reassuring at the bedside, to remind the child gently where they are, what time of day it is, provide familiar things. Don't argue with a confused child. That will probably just make them more aggravated. Distract your child with happy thoughts or images. Provide glasses if needed. Again, if they have a prescription, you don't want them to keep their glasses off too long. Help them stay in tune as much as possible. Help to keep a child safe during agitation. Encourage getting out of bed if medically allowed and being awake during the day. Encourage longer stretches of sleep at night, and explain to the child later if they have questions or remain upset about the confusion or hallucinations. A lot of times kids won't remember any of these things though. When someone's catatonic, they typically don't remember. If they are delirious, they typically will not remember it very well because the short-term memory is not transferred to long-term memory in the hippocampus very well. Other medication recommendations for delirium. So preventative administration is not recommended, but you may want to consider PRNs for anxiety, agitation, hallucinations, and sleep. You want to monitor for drug-drug interactions, weigh the risks and benefits. Typically, they use the same medications in adults as we do children. For benzodiazepine withdrawal, we use benzodiazepines or clonidine. Opiate withdrawal, fortunately, we don't see that too much, but again, something like clonidine or methadone. I don't think we would use methadone, though, probably just clonidine. Recommendations based on consensus, but not evidence. So IV or PO, haloperidol, PO, risperidone. We have olanzapine, but we'll use risperidone. We have olanzapine Zydus, which is the dissolvable. Sometimes we use that because it's a little bit easier. You just got to watch out for adverse effects because they are kind of compromised from a neuro standpoint already. So they may be more likely to have something like a dystonia, oculogyric crisis, that is where your eyes roll up in your head, akathisia, hyperpyrexia. You want to start low and go slow with medications. You want to check their scales and then wean gradually. What else here? This is just the dosing of Haldol and Risperdal in kids based on their weights. This is just IV Haldol. I think this came up the other day, actually, on a weekend. So this is that information for y'all there too. So we talked about biological causes for altered mental status that impact psychiatry a good bit. So here's some psychological. So it's biopsychosocial is what we usually look at. Psychologically, we consider emotional development. We respond, their responses to stressors, their self-esteem, their insight, their coping defenses, their patterns of behavior, and their pattern of cognitions. So psychiatric differential for altered mental status typically includes these things. So delusion, psychosis, mania, conversion, catatonia, which we mentioned earlier, due to its close relation to the medical side. Anxious and dissociative causes, so like trauma, panic, anxiety, cluster B, borderline traits, anger, obsessions, or compulsions. Also, we could consider like evasive and being evasive or dishonest. Someone might be evasive or dishonest in abuse, conduct, disorder behavior, malingering. The sick role, we have sick role issues sometimes too. Eating disorders, nutrition, lead exposure, heavy metals, and things like that, and then autism spectrum disorder. So what is a delusion? A delusion is a firmly held belief or impression that is maintained despite being contradicted. Common delusions are delusions of grandeur. I'm the most important person on the planet. Last one of these I had, it was in the case of bipolar disorder, and she was a billionaire, the best artist on the planet, and she had bunkers in 30 countries that she could hide in if the world ended. Persecution, people are out to get me. It's really kind of, I enjoy it when y'all rotate with me over at DJJ because it's important to distinguish, you know, persecution. Well, if you're robbing people and shooting at people on a regular basis, you know, it would be reasonable that they may want to persecute you. So it has to be probably more bizarre persecution. Government's plotting against me, things like that. Erotomania is always a fun one. Had a patient who, when he got manic, his delusion was that Britney Spears, Rihanna, and Ariana Grande were all his girlfriends. Delusion of being poisoned. Delusions of germs. We see that sometimes. I saw that once in a Panda's OCD case one time. And then sometimes, you know, being overweight can be perceived as a delusion. Some of our eating disorder folks can, they draw a picture of themselves. They'll be 80 pounds, but they'll draw a picture of a 300-pound person when they perceive themselves. More likely to see delusions though in psychosis, mania, eating disorder thinking, OCD thinking, and delirium. Also, definitely can see delusions in mania. They're rare under age 7 in middle childhood. You may see like simple irrational fears or cosmic threats, the world is ending type stuff. Cosmic threats, you know, a lot of times this age group does poorly with watching the Weather Channel. They tend to get fixated on tornadoes and bad weather and things like that. Delusions in adolescence typically are elaborate or persecutory. Some things that are normal, magical thinking, thoughts that lead to actions, upper limits, usually around age 7, and you can check the reality testing, you know, usually just talking to a kid, seeing if they're bizarre and oriented to see how they do. So differentiate delusions. So you want to rule out intrusive thoughts. So with OCD, you can see things like germs and things like that. Other things you may want to rule out is things like epilepsy, dissociation, and schizophrenia. We'll talk about dissociation and schizophrenia. OCD tends to have good reality testing. They know where they are. They're not bizarre. You also want to rule out autism spectrum. Sometimes these circumscribed preoccupations can get a little bit carried away. So you want to find out if that's their baseline or not. Specifics. So reference. So delusional references. Feel like people look and talk about you. Persecution. Again, you know, it's you're being chased by the FBI or aliens, not necessarily the kid that stole from you. A somatic delusion is that I'm missing body parts and I'm dead on the inside. Cotards is the name for that one. Oh, I misspelled it there, sorry. Bizarre delusions, demons, I'm possessed by a demon or something like that. Guilt, there's a delusions of guilt where you've done something wrong and they keep repeating over and over again how sorry they are. Again, you know, rule outs with the delusion, just obsessions, worries, poor concentration, specific phobias and social phobias are things to watch out for. Hallucinations. Hallucinations are rare in those younger than 7. Not every hallucination means that the child is psychotic. It's interesting with the medical students today. I found an article that showed 69% of children reporting hallucinations to the ER were behavioral disturbances, not a psychotic process. And typically when it's a behavioral problem, it's a voice told me to punch someone, or a voice told me to steal something or do something bad. Again, another study, the Dunedin study, 14.7 report hallucinations in Dunedin study, and a lot of them are not schizophrenic or psychotic. Risk factors are genetic predisposition, socioeconomic status, family emotional expression, victimization, and low IQ. So what's normal? Fantasies are normal. Kids have fantasies. They tend to have good reality testing. Certain fears, again, that are fairly normal, shadows by the closet or outside the window. It's normal to hear your name and not have someone call it. And they tend to have good reality testing. Content is variable. If it's variable, it's more likely schizophrenia. It could be organic epilepsy, degenerative disorders too. Guilt, if you have, if you're hearing voices that make you feel bad about yourself, typically, you know, it's like you're hearing voices saying you're awful, you're terrible, things like that. A lot of times that's related to psychotic depression. If it's bizarre, hearing voices or seeing things is usually a sign of schizophrenia. Again, if the reality testing is variable, you can have prodromal or schizotypal, where they start getting just kind of odd and weird. And then if it's pretty consistent, then it tends to be things like a schizophrenia, affective psychosis, or dissociative psychosis. Dissociative disorders tend to not have very much distress. They tend to not make efforts to stop it. Depression, they may or may not try to stop the distress. If affect is congruent, meaning they look sad, they may have affective psychosis. If it's incongruent, possessed by a demon, ha ha ha, laughing about it, that would be something more that you would see with schizophrenia. The differential diagnosis of early onset psychosis are things like psychotic disorders, disorders with transient psychosis, personality disorders like cluster C and cluster B, developmental disorders. Autism used to be childhood schizophrenia originally. Anxiety disorders. Kids with anxiety disorders often see shadows and think there's things that are going to get them. Disruptive disorders, like we talked about, I'm hearing voices that tell me to do bad things. And then substances, we've got, I saw like an 11-year-old that was dealing drugs down around the corner from here the other day. Kids are using substances earlier and earlier nowadays. So what do you do about affective psychosis? Well, if it's depression, then you treat the depression with Prozac, Lexapro, Zoloft, or Cymbalta. These are all indicated in this age group for both depression, OCD, or anxiety. Prozac and Lexapro are the only ones that are actually indicated in 10 and up for Prozac and 13 and up for Lexapro for depression. The rest have been tested safe in this age group. Bipolar disorder, I put that down below, and what to look for with that and how to treat it. And then schizoaffective disorder essentially is just a mix of bipolar disorder and schizophrenia. It's really kind of splitting hairs in treatment. So what is mania? A distinct period of abnormally persistent, elevated, expansive, or irritable mood lasting at least 1 week. During the period, the mood disturbance, 3 or more of the following symptoms have persisted: inflated self-esteem or grandiosity, decreased need for sleep, more talkative than usual, or pressured speeching, flatted ideas, distractibility, increased goal-directed activity, either school, work, sexually. Last time I saw someone that's manic, they cleaned the whole floor with a toothbrush. Excessive involvement in activities that have high potential for painful consequences. Well, that girl got pregnant due to hypersexuality, which is unfortunate. Buying sprees, sex sprees, foolish business investments. Usually I tell y'all about Dan the Man when y'all rotate with me. I apologize if I didn't, but we can talk about it later. Mood disturbance. Usually it's sufficiently severe to cause marked impairment in occupational, functional, social relationships. So it often necessitates hospitalization due to prevent harm to self or others. Again, there's usually, they feel like they have special powers, and a lot of times they do things based on those special powers that get them hurt. Like a lot of folks feel like they can fly. The symptoms are not due to physiological effects of substances. Again, typically not drugs, medications, ECT, or hyperthyroidism. And if you look at all these symptoms, how much do you see here? I got mad and punched somebody. Because bipolar disorder is very rare compared to conduct disorders or anger. So a lot of people in the region feel like they have bipolar disorder if they have a mood swing. They're happy unless someone makes them mad. But as you can see, this is not part of the criteria. What do you do about bipolar disorder? The ACAP practice parameters recommend lithium, which we really don't use too much. It does work, but it has a very narrow therapeutic window. Lamotrigine is a good medication. Just have to watch for Stevens-Johnson's with that. Olanzapine, quetiapine. Typically, we use our atypical antipsychotics to treat mania. Other things, anxiety. I'd say when I get called for altered mental status, 9 times out of 10, it's related to anxiety. So what do you have as far as anxiety goes? You have anxiety, dissociation, derealization, sleep issues. Anxiety can the way I think of it and explain it is anxiety can overwhelm the brain, much like a program can overwhelm the taskbar on a computer, leading to memory issues at the hippocampus, concentration at the frontal lobe, and even physical and motor symptoms. So basically, you ever notice that your computer freezes up? Why is it not working? You go to the taskbar and see one program is occupying 90% of the CPU usage. Anxiety can do that. It can just overwhelm the brain, and we can't think or act like we typically do. I think we had a case like a week or two ago where dad flew in from out of town, and he was upset with the girl, and the girl basically had a panic attack and couldn't think, and kept saying something over and over and over again, and that was related to anxiety. So she got hospitalized for that. PTSD is very traumatic. You see avoidance, hypervigilance, re-experience events with severe anxiety, memory deficits quite often. Sometimes that's a way that our brain protects ourselves from those overwhelming thoughts. Concentration and dissociation. Panic disorder, like that poor girl had. She had shakes, sweats, fear of doom, worries of future episodes, no triggers. She had shortness of breath, palpitations, lightheadedness, dizziness. You can have dissociation and derealization. Dissociation is where you feel like things aren't real, and derealization is basically like it's like a dream. Sometimes you can black out too. Dissociation can be blacking out. We will not remember it. Cluster B, one of the symptoms of cluster B or borderline traits is dissociation when you get upset, or derealization. You don't remember what happened, you black out. You got so angry or upset. With cluster B traits, you also have fears of abandonment, reactive moods where you get really upset. Borderline psychotic symptoms is where it comes from, essentially. They tend to feel like people are out to get them or plotting against them. There can be risk-taking behavior as well. A lot of parasuicidal behavior, cutting behaviors, and things like that. And again, anger. You can dissociate and black out in outbursts where you get too angry. And basically, you're just so angry you're not processing the short-term memory to long-term memory very well. Dissociation. This is when you have dissociation. You may forget things or have gaps in your memory. You may think the physical world isn't real or you aren't real. Again, it may feel like it's a dream or you're looking outside, looking at yourself from the outside. You may notice other changes in the way you feel. You may have out-of-body experience, like I said. You may feel like you're a different person. Feel like your heart is pounding, you're lightheaded. You can feel emotionally numb or detached. You can feel little or no pain, have altered sense of time, not remember how you got somewhere, have tunnel vision. You can hear voices in your head, have intense flashbacks that feel real, become immobile, or get absorbed in the fantasy world that seems real. And we talked about all the symptoms that may have that, or the conditions that may have that. I've seen this before, evasive, dishonest. Sometimes kids will be coy with us and won't give us straight answers. We see that in abuse. So we've had several cases where the kid was being abused and they thought if they told, then they would get hurt or somebody would get hurt. So they may be dishonest with us or forget things, or things may not quite add up. Conduct disorder, oppositional defiant disorder, again, to get out of trouble, externalize blame, things may not add up. They may have some altered mental status based on this. Malingering, to get out of trouble or have a secondary gain with only reported symptoms. The sick role can have secondary gain where they seem like they have altered mental status. Again, sometimes trying to stay in the hospital because it is wonderful there. It's like a hotel, and you have people that bring you food. You get to watch TV all day. Suggestibility. Sometimes kids will just say what they think. They'll just say whatever they think we want to hear. Factitious disorder, to get out of trouble or secondary gain with physical symptoms. I will not forget this kid that kept getting hospitalized over and over again. He claimed he got hit by something, but he actually did hit his head with a rock, so there would be symptoms from it. Another kid claimed that he got hit by a car and he took a rock and he hit his knee with it on purpose to have symptoms just for the sick role. Again, eating disorders, poor nutrition, restriction, deficiencies in vitamins can lead to some altered mental status. Pica or other exposure to lead and heavy metals can lead to some altered mental status. Autism spectrum, they can appear with catatonic, psychotic, fantasy type symptoms. Again, they often have a decrease in neuroplasticity and neuroresilience, and they can have unpredictable reactions to medications as well, or illnesses. Kids with ADHD, I've seen this before, where they can be distracted and inattentive, and it can worsen with stress. Conversion disorder. I know we don't really get this one too much, but anyway, I'm kidding. It's a condition in which you have physical symptoms of a health problem, typically neurologically, but no injury or illness to explain them. Your body basically converted the emotional and psychological stress into a physical or neurological response of something like a paralyzed arm. We had a girl over the weekend that was having spells where she would stiffen up and kind of make grunting noises and then talk funny. The symptoms are real and the patient cannot control them. They've done functional MRI studies on these folks with conversion disorder, and you can actually see that there's a link between the amygdala and the motor cortex, and they have actually shown that voluntary movements, the voluntary track has been transferred over to involuntary tracts. It's really interesting that they had that on functional MRI. Conversion symptoms. Conversions usually come on suddenly. They look like problems with your nervous system, like brain, spinal cord, or other nerves. You can have movements you can't control, like pseudoseizures. A lot of times we'll see them on a video EEG. The EEG will be fine. Blindness. Had a kid that fell, hit their head in the shower, went blind for a little bit. Loss of smell or speech. Had a girl who was having panic attacks related to doing her final speech for speech class at USC, and she hit her head in the shower and she couldn't talk again for a while. Numbness and paralysis that typically does not follow the tracks. A lot of time the typical thing you see is like stocking glove distribution. So the diagnosis, again, you have spells or something like that that affects your movement senses. You can't control them. You're not faking them. Can't be explained by other conditions, medications, or behaviors. Often it can be a diagnosis of exclusion. They're not caused by another mental health problem, and they cause stress in social and work settings. It has to have impact. So conversion treatment or reassurance that they're okay and that they can go on about their business is very helpful. Occupational physical therapy, again, if they have movement problems, like their legs won't work, then actually often you can kind of treat it like you would if it were an actual neurological problem. A lot of times that basically tells the neural pathways that it's okay to use these parts and they can be used again. Counseling, I think that's usually what we tend to do the most is cognitive behavioral therapy. We recommend that. My motto again in consults is, well, we know you got some stress going on, so let's address the stress and see what's left over. Hypnosis, I don't know who does that in town, but it's something that's indicated. A lot of times antidepressants or antipsychotic medications, again, addressing if there's a psychiatric diagnosis, addressing that can be helpful. Avoidance or reinforcement of the symptoms. I don't know if y'all seen our handout, but doing things like asking about it all the time, hovering, getting out of things like school or other stressors tend to make it worse. So it's important that they get back in a regular routine as soon as possible and that they not get any benefits from having the conversion. You can even use behavioral training where they lose privileges by having episodes and they earn privileges by not having episodes. And I've got a handout on that too. So just to continue with just the social components that we see in psychiatry. So social components and stressors tend to use the mnemonic heads. And I think I saw one of y'all, is it Marissa or something like that, that used their used heads in their note, and I was really impressed. But what is heads? Heads is home. So what's going on in the family? Who lives in the home? Socioeconomics, culture, things like that. These all contribute to stressors in a kid's life. Education, so school, grades, class type. This is, when I ask the top 3 stressors, usually it's what's going on in the home, like where they live, their living conditions, things like that, and what's going on in the house. And then school and grades is often a usually important thing. And then activities is usually the 3rd top stressor that I see is going on in a child's life. Activities, things like church, what do they do for fun? Are they involved with sports? Do they have goals? Like what do they want to do when they grow up? Social media. Social media has been causing all kinds of problems lately. TikTok and all that. Kids are just on social media too much and don't really have the coping skills to process what they see. Video games, electronics, things like that. Again, kids just don't necessarily have the ability to process what they're seeing on things like Grand Theft Auto or responsible electronic use. Adults don't have responsible electronic use, to be honest. Again, drugs is part of the social, but it's also bio too. And then S is sex, significant others, gender identity. This has been causing some problems too, some anxiety symptoms and some overdoses lately. But it's important that we ask the gender specific questions. What is their gender? What is their sexual preference? Those types of questions. And validation in that area is very important. Safe sex type questions too. Again, usually I do a sex, drugs, and rock and roll talk at the end with individually, because kids don't usually like talk about sex and drugs in front of their parents. And then that part is confidential unless there's a safety concern. And then at slide 64, it's amazing. Sometimes we just don't know what it was. Sometimes kids have these weird spells and we don't necessarily know what it was. A lot of times they tend to go, or the strange spells can actually resolve acutely. And then I tend to use my motto on consults. Let's address the stress and see what's left. So a lot of times, pretty much anybody we see, I do tend to recommend some outpatient therapy because I think, it's probably good for most folks. I imagine a lot of us could probably use a little bit of therapy here and there. It's not easy being a kid. Kids have a lot of stressors nowadays. So, any questions about this? And you want me to go ahead and email this to y'all too? Was that okay? Is that what y'all wanted?
Hey, Dr. Getz. Yeah, if you don't mind sending it to Whitney, we'll get it out to everybody.
Okay. All right. Any questions or any comments, or is there something else you wanted?
So one of the residents want to know if we do ECT here, and if so, how's that done? I'll let you answer that question.
Yeah, so we do ECT in Columbia. We have to contact Baptist. That's where it's currently done. Myself and Dr. Loper, we were both supposed to get ECT certified. I think we were supposed to go in March and April, but then something happened and called COVID, and we're not able to go. So it's in the works that we're supposed to do ECT here. At Richland, I think, is the last thing we had talks about it, but currently they're doing ECT over at Baptist. Dr. Snackenberg, and I think it's Dr. Huggins is the other one that does it, but they're, I think, in their 80s. So as soon as Duke gives me the go ahead, I am going to go to Duke and get certified to do ECT. But we do have an ECT suite at Baptist, and we have talked about doing ECT here at Richland. We did it with Shemaiah, so.
All right. Well, thank you, sir. We appreciate your time, and it was really helpful.
Yeah, thank you so much. Thank you so much. Again, any feedback, anything, if you want it differently or anything like that, or even stylistically, anything like that, just let me know.